Hello everyone. This presentation will be about traumatic brain injury, or TBI, based on some evidence-based peer-reviewed articles with empirical evidence on the treatment in working memory with patients with TBI. So this happens to be one of my favorite pictures, showing the left and right hemisphere, with the right hemisphere in a very colorful, creative format, and the left side a little bit less flamboyant and looking a little more analytical. So ASHA defines TBI as a form of brain injury caused by sudden damage to the brain. So the insult to the brain could be caused by an external physical force, such as the head being struck by an object, the head actually striking an object, acceleration, deceleration movements, which for example could be something like whiplash, because then it would not have a direct external trauma, nothing actually hitting the head. Um, Also, foreign body penetrating the brain, forces generated from blasts or explosions. So we're hearing a lot more about TBI because it's being related to war injuries. These veterans are coming back with injuries, with traumatic brain injuries from explosions and bullet wounds. So is the picture an open head or closed head injury? So here are some classic symptoms. The primary complications, meaning the initial injury, when that happens. We're going to be dealing with some of the secondary complications, things that will happen due to the primary injury. So some classic symptoms are attention, memory, and memory is what we will be discussing, confusion, cognitive and executive function skills are affected. There's perseveration, emotional regulation is very difficult to maintain, and it may contribute to brain ischemia due to the interruption in the blood supply. One thing that we need to be aware of is that this could take hours, weeks, months for us to be able to see. So what does this tell us about our assessments as SLPs? That they need to be done on an ongoing basis to monitor the progress and identify any new communication disabilities for ongoing treatment plans. So if we stop assessing after 1 week and many more complications happen after that, we are not treating what is actually happening. So here we'll be focusing on memory, its assessment, its evidence-based treatment plan of compensatory strategies. So let's remember that this is only one treatment that may be effective. Here's some incidence and prevalence statistics. We know that 2% of the population living in the United States are living with these disabilities which have resulted from TBI. So this shows us the need for educating the public and importance of our treatment. That's 5 million people. How could statistics of 2% of population having some form of disability from TBI affect our field? Well, TBI affects academic performance, comprehension and expressive language, syntax, semantics, sequencing, pragmatics, overall quality of life. So what is working memory? Working memory is the cognitive process used for the maintenance and the manipulation of information that is no longer available in the environment. Example of working memory is we're having a conversation and I'm saying to you, the lady went to the... You need to hold on to those words in your short-term memory while waiting for me to say that last word to be filled in order for you to understand the meaning of the sentence and the meaning I'm trying to convey to you for conversation. So that's considered part of pragmatics. Badley and Hitch defined 3 components in 1974, which we still refer to today. Um, those are the central executive system, and that is controlling attention, updates the information that uses sensory data, um, What happened when the information is no longer in the environment? We need to hold on to that information. The phonological loop is encoding the speech sounds being received, and it's temporary storage. It's necessary for the acquisition of language and vocabulary. Verbal information is entered automatically and stored in the loop. This transformation is facilitated by the articulatory control process, which repeats the series of words we're hearing in a loop, which helps us hold on to that information until it's no longer needed. So, like in the previous sentence, we need that information until we know the complete meaning when I finished my sentence. It also holds visual information, like the colors we see. It encodes visual information and separates object. For example, you know the location of where each one of your friends is sitting in your class when you walk into that classroom. So here's an example of the phonological loop with the central executive functioning in the middle, pulling and pushing the information in a loop. So here's a picture of where memory lives. Working memory is located in the prefrontal cortex. Memory is also located throughout the brain, and the process is about encoding, storing, and then retrieving. And let's remember that working memory is temporary. All of these neurobehaviors contribute to deficiency in memory. If we don't understand, if we are not able to plan or organize, if we can't attend, then language and communication cannot be formed. The neurobehavior of language and cognition actually depends on this. Recovery of prefrontal function prevents full reintegration into society sometimes if the patient can't produce language. This can affect being able to associate simple relationships, things like synonyms, antonyms. They have solving skills issues, and those are needed for comprehension and expressive communication. One assessment tool is the Rancho Los Amigos scale of cognitive levels. There are 10 categories of assessment. As you can see, there can be moderate to severe deficits in all of these areas. When providing treatment, it's important to consider these behaviors. Is the patient restless or tired? Can they continue with our timed session? Are they able to attend to our directions? Are they able to remember what and why we are administering treatment for them? Remember that in working memory, it is a mental space. Here's where the cognition comes in. This is what is needed to process information. So, what does this all have to do with language, you ask? Well, if cognition, attention, memory, reasoning, and executive functioning is impaired, then so is our ability to communicate. So, here are some impairments: the poor comprehension, can't stay on topic, and so on. It also all will depend on the severity. This might be the most important goal to keep in mind. The World Health Organization defines the goal of intervention in traumatic brain injury is to achieve the highest level of independent function for participation in daily living. Once again, measurable and functional changes. So we do need to take into consideration that it's an evolutionary process and the changes in the recovery process, cognitive, physical, and behavioral, are continuous, including sensory issues, tactile issues. We may not know what is damaged unless we continue to assess and treat. We must be patient and understanding. Once again, measurable and functional changes for that particular client. It was thought that remedial intervention would help with restoring lost functions, but found that it is not as effective with brain injury as it was thought. It was too task specific in therapy and too hard to generalize. Bottom up approach is attempting to restore lost function, which may not be possible for a person with TBI. Compensatory approach uses strategies, environmental modifications, intact cognitive skills that are already there to be able to program the compensatory skills and for the patient to apply them in their own lives. In order to achieve this generalization, the patient has to have an understanding of their memory loss and motivation to employ these strategies. So self-awareness is a high-level cognitive task and sometimes deficient after brain injury. Therefore, self-awareness assessment and/or training is needed prior to treatment. So in order for compensatory strategies to be effective, we do need to personalize it. Find out what their daily routines and schedules are. Work on what's currently functional for them, going to the bathroom, eating, taking their medication. Do they need to focus on a goal for a job if they're employed, and then target that environment. It's very important to have family members and caregivers as part of this process. We must prioritize their tasks. They may not be able to cognitively prioritize. Hopefully, after a while, we can teach them how to program their own devices. Empirical evidence has shown that first we need to make sure our client will buy into external strategies. We need to make sure that we know their level of cognition, their vision, their hearing, fine motor coordination, and their reading comprehension. Here are some external aids like written reminders, memory books, scripts, and you can see in the notes how to use and how we might help the client understand how to use all of these strategies. Some more external aids. The Watchminder is really great, and so is the VoiceCraft for their memory. But once again, it really depends on their cognitive abilities. A controlled treatment study by O'Neill, Perozzi et al. Concluded that internal strategy techniques may be beneficial, and they also did mention that even more beneficial when working in conjunction with the external aids, especially for us as SLPs. Some of these treatment strategies are very important. Semantic association, semantic elaboration, chaining, imagery. Mnemonics may work better for mild impairments because it is something that you would have to remember. And there's some examples of treatment options in the notes. Some more treatment option activities for internal strategies. Is this treatment effective, and how do we know if the treatment is effective? Well, we do have empirical evidence and data that shows us that these have positive treatment efficacy. The evidence shows that a combination of external aids and internal strategies in treatment really is the most effective. Patients went from maximal cues to very few cues for eating, taking medicines, bathing, appointments, things that are very important in their everyday lives. So through the empirical evidence research, we see that the population varies in severity, cognitive abilities, motor abilities, and that's very important when taking this compensatory strategy treatment into account. ASHA requires this of us, and it's the most effective form of treatment if it's up-to-date evidence-based practice and empirical evidence. So compensatory strategies is only one method that evidence-based research shows to be effective for the TBI population.
Memory is the ability to encode, retain, and recall information, and it's something that we use every day. It's memory that allows us to remember birthdays, recall names, remember appointments. It's memory that allows us to recall the taste of chocolate, the smell of coffee, and important activities in our lives. Memory is one of the things that families who we support find most challenging following a brain injury. It's no wonder that memory is affected following this injury because of the way that the brain organizes and stores memory. Families will often report that their loved one can recall very specific information about long-term memory, things that happened 10 years ago, or highly detailed information about their childhood, while they're having difficulty remembering things that happened in the recent past, such as what they ate for breakfast or what they wore yesterday. When we talk about memory, we're really talking about different types of memory. Immediate or short-term memory is what allows us to recall information for short periods of time. It's this memory that allows us to recall a telephone number long enough to write it down or to dial the phone. It's often this immediate or short-term memory that is affected following brain injury. When someone sustains a traumatic brain injury, there may be one area of the brain that is affected. There may also be a hypoxic or anoxic event in which there's not enough oxygen to the brain or no oxygen at all. While this affects the entire brain, it has a very significant effect on a deep area of the brain called the hippocampus. The hippocampus is deep inside on both halves of the brain. And this is the structure that is associated most strongly with the ability to encode information and store it for long term. Also, the hypoxic event or the anoxic event can have an impact on the entire brain, which does maybe not allow the brain to function as well in attending to information as it once had. So someone's ability to pay attention to various things that their senses are taking in has been affected. And it's no wonder that that does not allow for the best encoding and storage of that information. While there's no cure for memory impairment following brain injury, there are many strategies that can be used. And families often report that these work well to improve the lives of those individuals who experience significant memory challenges following their brain injury. It's important to have a well-developed routine, which allows for predictability, which also will ensure that someone can practice these strategies throughout their day. Many individuals benefit from having a diary or ability to keep information in a written format. Not only does that allow them to later recall information by looking at it, but the act of writing the information down helps to further encode and practice and rehearse that information. Many individuals will use internal strategies as well. They may use acronyms, which each letter of the acronym will help them to remember something that's important to them. They may rehearse information. They may structure their environment in a way that allows them to have notes and other memory aids kept in special places that will cue them for some things that they want to recall. They may also utilize external memory aids, such as electronic devices that will help them to record important information. It's important to develop a categorization strategy, which allows you to determine which ways you're going to use this information. Accessing a qualified provider of brain injury support services and rehabilitation will ensure that you are seeking a qualified individual to help create a program that allows for the maximum practice of these strategies throughout your day.